Good afternoon, ladies and gentlemen. I'm Dian Martasari from Cardio-Respiration Division, Physical Medicine and Rehabilitation Department, University of Pajajaran Hasan Sadikin Hospital. My topic today is maintaining lung compliance and airway clearance in neuromuscular disease. This is my curriculum vitae. I was born in Yogyakarta, and I'm a staff lecturer and medical staff in Universitas Pajajaran and Hasan Sadikin General Hospital. Okay, so this boy, he is 8 years old now. He is spinal muscular atrophy type 1. And he lives using ventilator. So as we know that neuromuscular disorder has so many type of disease, and some of it is very rare. So it also a genetic disease like a spinal muscular atrophy, Duchenne muscular dystrophy, Becker, Pompe disease, and so many others. Patients with neuromuscular disease, they will have progressive weakening respiratory muscles, develop restrictive pulmonary disease pattern, such as decreased lung compliance and scoliosis, and also respiratory complications such as cough, repeated infection, and it can cause morbidity and mortality. The pathophysiology of the disease in neuromuscular disorder is ventilatory muscle failure. It is caused by inability of inspiratory and expiratory muscles to sustain one's respiration. Ventilatory insufficiency leading to failure can be nocturnal only, and it is resulting from diaphragm dysfunction, lack of central ventilatory drive, or severe generalized respiratory muscle dysfunction. The sign of ventilatory insufficiency is hypercapnia, which is in presence of a normal arterial alveolar gradient. This hypercapnia, it is not caused by intrinsic lung disease or irreversible upper and lower airway obstruction as in chronic obstructive pulmonary disease. Airway obstruction from bronchial mucous plugging can cause elevated arterial alveolar gradient, and symptomatic hypercapnic patients will benefit from use of non-invasive ventilation for at least part of the day and most often overnight. Patients with progressive inspiratory muscle weakness, ventilatory free breathing ability eventually can be lost. And patients without ventilator use, it can cause increasing severe hypercapnia and also a coma due to carbon dioxide narcosis or ventilatory arrest. However, bulbar muscle dysfunction in ALS patient, which is the oxygen saturation below 95%, it is because of continuous aspiration of the saliva and irreversible upper airway obstruction. This patient requires tracheostomy tubes to protect the airway. The epidemiology of neuromuscular disorder 500,000 people in USA, and in myopathies, DMD, 1 out of 3,500 boys. In neurological disorders such as SMA, spinal muscular atrophy, 1 in 5,000 children. ALS, 1 in 1,800 people. What about in Indonesia? This data, I got this in 2018, and it tells about the patient with SMA in 2017, about 29 patients, and in 2018, there were 52 patients with SMA. The distribution type of SMA, which is the highest number, is type 2 SMA in Indonesia in 2018. This is also the distribution patient with SMA in Indonesia in each city, or each province. So we can see 24 patients, the highest number, and it is located in West Java. So what are physical medicine respiratory muscle aids? It is inspiratory and expiratory muscle aids about manual or mechanical application of forces to the body or intermittent pressure changes to the airway to assist inspiratory or expiratory muscle function. Patient's evaluation from anamnesis, we can get patient can walk, but they complain exertional dyspnea, morning headache, fatigue, sleep disturbance, or hypersomnolence. Patient with wheelchair user, symptoms may be minimal, except during intercurrent respiratory infection, when anxiety, inability to fall asleep, and dyspnea. The other evaluation is inspiratory and expiratory muscle strength. We measure the maximum inspiratory and expiratory pressure. So this is the video how we measure the inspiratory and expiratory muscle strength. Okay. So this is the muscle expiratory pressure we measure while the patient exhales. Okay, Phyto Capacity is also important, and it is said the most important indicator of ventilator dysfunction. Hypoventilation is often worse during sleep, the supine rather than sitting position. So Phyto Capacity, it is also indication for both parameters. It is simple, easy to measure, objective, and reproductive. Cough peak flow. It is a device to measure the patient's ability to cough. 160 liters per minute. It is a minimum value or minimum needed to eliminate airway secretion. In the other way, if we don't have the device to measure the cough ability, we can use the Phyto Capacity. If the patient has Phyto Capacity less than 1,500 milliliter, so this patient must be assisted in coughing. So the ability to cough is low. Gas analysis is also an evaluation in neuromuscular disease, but arterial blood gas analysis is unnecessary because during the procedure, the patient can feel anxiety or pain, so it can cause hyperventilation in 25% of patients. So we need non-invasive continuous blood gas monitoring using capnography and oximetry, particularly during sleep. Nocturnal non-invasive blood gas monitoring. Any symptomatic patient with decreased vital capacity and nocturnal oxyhemoglobin desaturation below 95%. It is also a sign that the carbon dioxide pressure nocturnal is increased. So this patient requires treatment for nocturnal hypoventilation. Oximetry feedback, it is very important during management of upper respiratory infection. The goal is to maintain the oxygen saturation higher than 94%. If it is below 95%, the oxygen saturation, so we can say that this patient has underventilation or bronchial mucus plugging. And if it is not quickly addressed, it can cause atelectasis or pneumonia. So the intervention objective in neuromuscular disease or disorder is to maintain lung and chest wall compliance, to promote lung and chest wall growth for children. Maintain normal alveolar ventilation around the clock, and maximize cough flow or cough ability. So for the first goal, to maintain pulmonary compliance, as we know that vital capacity is decreased in neuromuscular patients, ability to expand the lung is lost, and the pulmonary or lung compliance also lost. So this patient needs regular range of motion to prevent chest wall contracture or lung restriction. We can use methods such as deep insufflation, air stacking, nocturnal non-invasive ventilation. So for glossopharyngeal breathing, it is to assist the inspiratory and expiratory effort. Patients with weak inspiratory muscle can also use this glossopharyngeal breathing. The other method is air stacking, and the goal of air stacking is to increase vital capacity, maximum insufflation capacity, maximize cuff peak flow, maintain or improve pulmonary compliance, prevent or eliminate atelectasis. Patient with vital capacity less than 70%, we can give air stacking 10 until 15 times, at least 2 until 3 times daily. And the first respiratory equipment is manual resuscitator. And this is the video about air stacking. This video show only 3 cycles, but usually need 10 until 15 cycle and repeat it 2 until 3 times a day. For infant, in SMA type 1 or 2 cannot air stack or cooperate to receive maximal insufflation. We can see the paradoxical chest wall movement, and we can use nocturnal non-invasive ventilation to prevent pectus excavatum and promote lung growth as well as for ventilatory assistance. Children with age 14 until 30 months old can cooperate with deep insufflation therapy. The other goal for intervention in neuromuscular disease is to provide functional cuffs by assisting expiratory muscles. Why are the expiratory muscle aids needed? It is for effective cuffing. So we need the bulbar, inspiratory, and expiratory muscles to be intact. To improve or to increase clearing airway secretion and prevent chest infection. We can use the manual assisted cuffing, but we have to use maximal insufflation before manual thrust for assisting cuffing. We can give glossopharyngeal breathing or air stacking as a maximal insufflation. This is the video for manual assisted cuff. So we ask the patient to breathe in normally, deep breathe in and then cough. And for manual assisted cough, we assist the patient with abdominal thrust while the patient coughing. And the newest one is a device, we call it mechanical insufflation exsufflation, to help the insufflation exsufflation for patient so he or she can cough. We use the pressure 40 and minus 40 centimeter water via oral nasal mask, mouthpiece, translaryngeal, and tracheostomy tube. We use this method, the manual assisted cough or mechanical insufflation exsufflation, 5 cycles with a short period of normal breathing, and every 30 minutes during the chest infection. This is the picture of the device. We call it cough assist. So the other method or the other intervention for neuromuscular disorder is maintaining the respiratory muscle strength and endurance. We use the inspiratory resistive exercise, but it has no effect on spirometry or maximum inspiratory and expiratory pressure results, but it can improve respiratory muscle endurance. For patients with vital capacity less than 30%, this exercise is ineffective, and this patient will require nocturnal ventilatory aid. So this is the equipment for neuromuscular disease assessment and treatment. First, we need the capnometer or capnograph. The second, we need micro RPM to measure the maximum inspiratory and expiratory pressure. Pulse oximetry to measure oxygen saturation. Handheld spirometry to measure vital capacity. Peak cuff flow to measure the cuff ability. And ambu-vac to give maximum insufflation or deep insufflation to neuromuscular disease patient. Thank you. I hope that it will give more information for all of you.